First, I'd like to begin by acknowledging the traditional lands. I'm on the Wurundjeri lands of the Kulin Nation. I'd like to acknowledge elders past and present, elders from other cultures, Aboriginal people with us today, and that this is and always will be Aboriginal land. Today's webinar is part of the Tri-Peaks project, which is a collaboration between the Centre for Excellence in Child and Family Welfare, the Victorian Healthcare Association, VHA, and the Victorian Alcohol and Drug Association, or better known to all of you out there as VADA, to support the integrated practice and good governance across our three sectors. This is a Zoom webinar, so please use the chat and Q&A functions for your questions and comments. At the end, if we have time, we will also be able to have a bit of a Q&A session. But I say if we have time because it's only an hour. In today's webinar, Professor Leah Bromfield, Rethinking Child Protection System Design Assumptions for Families with Multiple and Complex Needs. Now, that's a bit of a tongue twister, but that's the title of today's session. We've had an enormous interest in today, so we're very much looking forward to today's session. So let me just introduce Leah to you. Professor Leah Bromfield is one of Australia's foremost child protection researchers and is co-director of the Australian Centre for Child Protection. She is a well-regarded research expert in issues affecting child protection systems, chronic maltreatment, cumulative harm, and has worked closely with state, national and international governments on establishing and implementing child welfare reforms, including the National Framework for Protecting Australia's Children. Professor Bromfield was the Professional Fellow to the Royal Commission into Institutional Responses to Child Sexual Abuse, established by the Australian Government, and led its extensive research program. And she also won the 2017 Telstra Business Award for Public Sector and Academia. I know many of you know Leah's name and have seen her work, and we're really pleased to have her here today to speak with us. So without further ado, I'm going to hand over to Leah to speak with us this afternoon. Thank you, Leah.
Thanks so much for that introduction, Deb. And I'd also like to acknowledge that I'm speaking to you today from Ghana country, and pay my respects to elders past, present and emerging, and extend those respects to the traditional owners of the lands on which you are each living, working or learning today. Now I'm just going to share my screen. Sorry, my mouse is being a bit non-responsive. There we go. Now, is that up for people yet?
Leah, the slides aren't up. You're sharing your screen. We just can't see the slides at the moment.
Okay, let's stop that. Let's start all over again. Sorry, everybody.
Not at all.
Right.
There you go. Thanks, Leah.
Okay, great. I should just stop pressing buttons and be patient. I want to thank all of you for taking the time out in your lunchtime today as well to listen to this this presentation. I hope that you find the information useful. This is the wrong slide set.
That's okay. Just take your time.
We have the right one now, Leah.
You can see the right slides now?
We have the right slides now.
And can you see that as full screen?
Absolutely. Thanks,
Perfect.
Leah.
Okay. I also wanted to acknowledge Professor Fiona Arney, Associate Professor Alwyn Chong, Dr. Olivia Ockerman, Dr. Sarah Cox and Jenna Meeksons, who are researchers at the Australian Centre for Child Protection, who have undertaken some of the analysis that I'll be presenting today. In particular, I wanted to acknowledge Professor Fiona Arney, who was the lead researcher on a lot of the new data I'll be presenting. I wanted to acknowledge the Aboriginal Leadership Group, who provided the cultural governance for the data that I'll be presenting today. The South Australian Government, who funded the work, and the South Australian Department for Child Protection, who opened their doors to us incredibly bravely and said, you know, we really genuinely want to know what's happening, and actually co-authored some of the papers with us, the CEO and Deputy CEO. So what I'll be presenting today is mostly some data from research that we undertook in South Australia. This research fundamentally changed the way that I think about child abuse prevention and child protection reform, and has changed the type of advice that I'm now giving to governments about how best to intervene and prevent child abuse and neglect. So I really appreciate the opportunity to share it with all you today, because I think if you get something wrong, it's really important to tell it far and wide. It really has absolutely changed the way I've thought. The research was primarily undertaken in South Australia, but the characteristics and features we see in the South Australian child protection are the same as what we see in other child protection systems across Australia and internationally in the US, Canada. So the findings have relevance. Now, this slide I've got up today is one that we've all seen before. Essentially, in the last decade, with some peaks and troughs, we've seen a continuing upward trend in reporting to child protection. Dr. Leah Bromfield from our centre has looked at these reports a little bit differently. What she's done is said, well, what does that really mean, lots of reports? And she's looked at it in terms of what we know about the proportion of each birth cohort. So, for example, of all the children born in 2011, how many were reported to child protection? And when we look at it this way, we see this similar upward trend over time. And in the most recent data, we can see that 1 in 4 children in South Australia are reported to child protection by age 10. 1 in 4, that's double the rate of childhood asthma. And 1 in 2 Aboriginal children are reported to child protection by age 10 in the Northern Territory. These are really shocking statistics. Now, against this backdrop, we've seen over a decade more than 40 independent inquiries into child protection systems. And these inquiries consistently tell us that child protection systems have been unable to cope with demand, that they're fractured, inefficient, and are failing our most vulnerable children, and that we've really seen no real improvement despite repeated cycles of reform. That depresses me to say, because I feel so much a part of this system. So what have been some of the assumptions that we've had when we've been reforming child protection? Well, really, we've kind of operated on the same assumptions since the 1990s. And that is that risk is incremental. So kind of families come into services with maybe 1 or 2 risks, a certain amount of vulnerability. If we don't intervene with those families early enough, then that risk will continue to accumulate and grow over time, and we'll see them incrementing up a pyramid of need until we see their children being abused and neglected, and them needing statutory child protection involvement to keep their kids safe. Part of that assumption is as a subsequent assumption that as risk increases, the size of the affected population decreases. So the largest amount of families in the community are those with no known risks, and the smallest amount will be those who end up in our out-of-home care system. And we see kind of vulnerable families and then maltreating families in the middle there. Now, these, I say, are assumptions because we actually as a system, we've not gone and tested all of these assumptions. We don't know that these are the facts upon which we've based our systems. Now, another assumption that we make within this is that we've got all these reports to child protection because we don't have enough services for vulnerable children and families, and therefore those reports are about trying to get help for families who are in need rather than being genuine cases of children in need of statutory intervention. And that's why we need to screen reports, and that 3 out of 4 reports are actually screened out of child protection on average. Now, the research that we've undertaken has fundamentally changed my thinking about these assumptions. In fact, I think these are wrong and that we need to stop reforming child protection based on these assumptions. I'm going to talk to you about why, and then I'm going to tell you what I think our new assumption should be to reform child protection systems so that we actually see some significant change in the demand and on those systems, and that we're better serving families in need. So what we did in this research was to actually return to first principles to test these assumptions. As a nation, we've said that we would take a public health approach to the problem of child abuse and neglect, but the reality is that we skipped the first step. We didn't do the epidemiological work of understanding how big the problem of child abuse and neglect really was in Australia, who was affected, where, when, what were the critical points of intervention. Without that first step, we're really reforming in the dark. So what we did was we undertook a series of studies where we actually went into the details of child protection reports. We weren't interested in what child protection said was happening from its screening. What we wanted to look at was what was the narrative? What did we actually know about what people were worried about with these families? What did we know about the characteristics of the families? So in case file review 1, our aim was really to explore the idea of pregnancy as the earliest point of intervention. So we looked at a 20% random sample of women who were reported during pregnancy in 2014. What we found here was that we actually had two really clear typologies of reporting. The first typology was for women who it was their first time pregnancy. The second was actually women who already had children who were involved in the child protection system. And they were by far the larger proportion of the sample. Hang on, I'll just go back here. So you'll see that 66% of the sample fell into that second group of women who already had children who were involved in the child protection system. And only 20% were first-time parents. Now, they were all first-time parents who actually had their own abuse history and mental health concerns. So they were first-time parents who, I would say, already were presenting with multiple and complex needs from that very first pregnancy. We saw very, very high rates of violence in both groups, but clearly higher rates in the second. And alcohol and other drug use was also very high. As I said, all across both samples, we saw mental health concerns related to childhood trauma and abuse for all parents. From there, what that kind of told us was that we needed to look at families. You know, we look at child protection data often from the point of a child, and a lot of our service design and evaluations are actually assuming that there's kind of one child in the family. Now, those assumptions about incrementing risk, they start with the idea that we've got one child in the family and that risk increments up. What we saw was that for women who were reported antenatally, the largest proportion of them actually were very well known to child protection. So we needed to look at family risk, not just the risk to the infant. So in the second case file review, we were interested in just who came through the door of child protection. So we did a random sample again of 20% of reports within a particular geographic region, a metropolitan region. It wasn't the best, it wasn't the worst in terms of socioeconomic disadvantage. It's kind of an average child protection region in South Australia. What we found here was that when we looked at a single child level, about 40% of the children were re-reported within 6 months. Now that is the indicator that we use on the report for the report on government services. When we looked over 8 years, we saw that almost 90% of the children had actually been re-reported to child protection. And when we looked at a family set level, we were hitting that 90th percentile and getting up to a ceiling effect of re-reporting. Now, what does that mean? What does re-reporting tell us about families? One re-report may or may not mean much. We then split it down to look at, well, how many reports per family? Now, what we saw here was that actually re-reporting was by far the norm and quite high levels of re-reporting. So 1 in 4 families in our sample, so there's this 20% sample of just families coming through the door, were reported to child protection 20 or more times over the course of their family life. That's incredible, 20 or more reports for 1 in 4 children. Again, what does it mean? If we've just got lots and lots of reporting because we've got lots of vulnerability and people are trying to get into services for families, maybe reports mean nothing at all. What I'm going to show you next is this slide here, which shows, and I'm just going to present one of the slides, the charts on family characteristics. Now, what this shows is that there's a linear relationship between the number of reports and the amount of risk and need within the family. And you'll see for that group there on the far right-hand side with the 20 or more reports that levels of family violence were over 90%. We had alcohol and other drug misuse, mental health concerns, criminal behaviour, all over the 80th percentile. So incredibly high rates of risk and need within those families who had the most number of reports. It's really important as a take-home message, because this means that there's a linear relationship between number of reports and risk. So reporters are actually reporting the most about families with the most problems. I think that we've probably been giving reporters a bad rap in our system by suggesting they've been hyper-vigilant or over-reporting. It's clearly strong judgment here with the most reporting about the families with the most amount of risk. Now, I'm just going to slip in here. This is some data from the Better Start group at the University of Adelaide. And this also shows a clear link between child protection outcomes and being reported to child protection. And what you see here is more than double the number of children with 1 or more developmental vulnerabilities on the Australian Early Development Census for those children who were reported just once to child protection, regardless of whether it was screened in or screened out, compared to those who were never reported. That's quite phenomenal. And that dotted red line that you see there on the chart is actually the state average for children with 1 or more developmental vulnerabilities on that AEDC. And that's from a sample of 54,000 children over the 2009, 2012 and 2015 censuses. So yes, our research is a small sample, but the AEDC certainly at a population level backs up this relationship between a linear relationship between number of reports and risk and need. If we look here at families with extreme involvement, we were really interested in this because what we saw was a really distinct set of characteristics, almost like a profile. This is quite important because it means that a proxy indicator like number of reports can actually help us in thinking about service planning and referral. So for families with extreme involvement, which was that 20 plus reports, we saw that almost universally these families had a parent under 20 at the first pregnancy. Now that's a parent, mum or dad, not just mum. Multiple children. In fact, the mean number of children in these families was 7 children. And again, this is 1 in 4 of the families that were reported to child protection. So very large numbers of children. Now, I've got 2 kids and parenting is hard some days. Parenting 7 children when you've got multiple and complex needs, that's a really, really challenging task. We saw multiple repartnerings, so 3+ of significant repartnerings. That's where you start seeing blended families, stepchildren, additional caregivers involved in the mix, and again, where life starts to get much more complicated and we're seeing families spread over multiple households. We saw, as you saw in that last chart, really high levels of intimate partner violence, alcohol and other drug misuse. The 3 most common were alcohol, marijuana and methamphetamine, mental health issues, criminal behaviour and homelessness. We saw very high levels of child and adolescent mental health concerns as well, and quite high levels of suicidal ideation in very young children, and youth justice involvement, which we didn't see in the other groups, only in this, this group of the families with the extreme involvement. And in fact, what we were seeing was children's risk factors were mirroring the risk factors of their parents. This slide here shows, for those families with the 20 or more reports, the outcome of child protection screening. Now, there's lots of acronyms on this slide, so let me tell you about it. So this is really when someone makes a report to child protection, and child protection needs to make a decision about whether they are going to screen out the concern and say it's a notifier only concern. It's not about child abuse and neglect. Whether it gets classed as a report on an unborn child, a concern about an adolescent at risk, extrafamilial child sexual abuse, whether it's screened in as a child protection matter. And for those cases that are screened in as a child protection matter, then they allocate that case as either a tier 1 or a tier 2, and that indicates the priority. So tier 1s, there's an expectation of a same day response, whereas for tier 2, the aim is to get out within 10 days. Now, this is the only data where we didn't see a linear response between the number of reports and the data. In fact, it's what we saw was the families who were extremely involved in child protection just had more of everything. They were more likely to be screened out by child protection. They were more likely to be the subject of an unborn child concern, more likely to be have an adolescent at risk, more likely to have allegations of child sexual abuse, and more likely to have screened in child protection referrals than any of the other groups. This is really important as a finding, because one of the key ways that that child protection actually make referrals is off that initial triaging screening decision. And for those of you who are working in child protection in the audience, for those of you who might be working in family support services, then for those cases that are screened out for child protection, but where there's assessed to be need for the family, then those referrals will typically go straight through to family support services. Now, it's really important to remember that that's based on the presenting incident. So we're referring based on an incident, not the global risk that's presenting in the family. I think this is creating quite a problem for us and for practitioners who are working in family support services. When you say, you know, families are getting more and more complex, I think you're totally right. They really are getting more and more complex. Now, the next thing the last bit of analysis that I'm going to share with you today is something that we did where we really wanted to follow up further on that finding that we could see that distinct set of characteristics for the extremely involved families. And what we wanted to look at here is really whether we could identify subgroups of families and whether that could help us to identify what populations were contributing to the greatest demand and the optimal windows for intervention. So rather than relying on the child protection screening outcome, we're really looking at, is there a different way of thinking about this? Because we're really worried that the child protection incident screening decision is not the best means of defining families. That incident-based screening is about a point in time incident. Again, it doesn't tell you about the global risk to the family. We might see a report on one day that is about a child who's where there's a concern about the child not having food in their lunchbox, you know, a neglect concern. Whereas, you know, 3 days ago, we saw a report that was about a significant domestic violence incident where police attended and the child was seen displaying, you know, really strong trauma symptoms. We're just not putting that together when we refer based on the screening decision for an incident. So what we did here was we took a subset of those families from the case file review, the second case file review about repeat involvement, and we created individual case summaries in a set format for all of the reports that were recorded for that family. So over an 8-year period, which is the period we had data for, that we could go backwards in time until, that's over 12,000 reports that we assembled together into these, at a family level, into individual case summaries. We had a set format for that where we would look at current orders, we would look at, in terms of police, family law, the current concerns that were being reported by the reporters, and then the recent concerns over the last kind of 6 to 12 months, and then historical concerns within the family, which often, as you would know as practitioners, tell us a lot about the current presentation for children. We then went through a process of essentially a clinical case conceptualisation, kind of what's going on with the family, what are the clinical needs, what are the risks that are presenting for each family group, and thinking about that for each member of the family group. Now, following that activity, we went ahead and created a visual representation of the risks that we were seeing accumulating for families over time. We call this the trajectory. And what we observed was that consistent with those case file review 1 findings about women who were reported in pregnancy, children were being conceived into families with multiple and complex needs. And I'm just going to talk you through this trajectory here. So we start with a mum who has a complex trauma history. This is kind of the majority pattern, and we've mapped this based on the primary age of onset that we were seeing these risks presenting at. So parents with a complex trauma history at conception, presenting with mental health concerns. We're already seeing violence in those first-time parents. We were seeing some repartnering already, and alcohol and other drug misuse. So we had a really complex situation from that very first pregnancy. We then see Bub being born into this environment, and then our babies who are born into this environment have got a much greater risk of fetal alcohol spectrum disorder, a failure to thrive, of birth defects, of family law court involvement, really early in childhood. And with each, you see the arrows go across the page here. As the children are developing, they're accumulating more risk unless we can disrupt this trajectory and intervene in both the family and for the child to try and actually heal some of these harms. But what we're seeing is violence, abuse and neglect continuing across the life course. And so by the time you get to early childhood, we're seeing children at much greater likelihood to display global developmental delay, to be diagnosed with ADHD and autism spectrum disorder. We see our clinicians suspect that a lot of that diagnosis is actually misdiagnosis of complex trauma symptomatology. We're seeing higher rates of intellectual disability, greater vulnerabilities on the early development census, and physical health and hygiene issues. By the time we were getting up to preteen and early adolescence, we were seeing our kids starting to display quite early mental health concerns, including self-harming, trauma responses, suicidal ideation, school absences, unhealthy weight. And as adolescents kind of continued, we started seeing them mirroring the problems of their parents. So being in relationships themselves where there was violence, starting to use alcohol and other drugs, seeing early onset of sex and pregnancy, youth justice involvement in offending, homelessness, youth homelessness, and educational disengagement. And the sad thing about this is that we then see with that with early pregnancy, our kids becoming the next generation of parents. They kind of go right back to the beginning of this trajectory, and become that young parent under 20 with a trauma history themselves. Now, it's a pretty dire life trajectory for a child if we don't disrupt this cycle. But if we think about it in terms of families, what we're seeing is parents with multiple and complex needs. We're seeing multiple children with
I think we have a frozen screen, Emma. And
pattern
there we go.
involved with child protection. Sorry, we've got an issue with...
No, you froze momentarily, but you're back with us, Leah. It's all good.
So yeah, over a decade ago, I said that families with multiple and complex needs were the majority of families involved in child protection. We've been using this term for such a long time, and in the past I've used it to refer to really that toxic trio in particular. So where you've got domestic violence, mental health, and alcohol and other drug misuse. This is a really misleading way of speaking about multiple and complex needs, because it implies that there's three problems within the family. But where we have that, where we've got parents who are still dealing with they've not yet recovered or done the healing around the trauma they experienced as kids, where they're experiencing active domestic violence, unmanaged mental illness, where there's active substance misuse, then the problems that we see kind of cascading out from that are innumerable. You see these recipe lists of risks and needs for families and for each individual within the family. And I guess over the course of my career, I've really seen the proportion of families with multiple and complex problems increasing, but also the complexity within those families increasing. The emergence of methamphetamine as one of the primary drugs that we were seeing parents involved with child protection using has changed the presentation of families. The severity of violence that we saw within families was far greater than I've seen in the past. I compare this to a population where I did an almost identical kind of methodology when I first was looking at cumulative harm in Victoria in kids born between 2000 and 2004 that were reported to child protection. The most reports I saw in that study was 22. That was the top, my ceiling. And the families just did not look like this. So the complexity of families has certainly changed over the course of my career. Now, in this slide, you'll see that what we've done is overlaid an age segmentation by the age of the eldest child on top of this trajectory, and included in that the mean age. The mean number of children, the mean number of kind of significant partnering relationships for parents, and the mean number of reports to child protection. I just want to note as well, I've talked about reports. These are all unique reports. So it's about a different incident each time. So if you've got 5 kids in a family and someone's reported about all of the children being left unattended, we counted that as one report. There was no double counting of incidents to make the numbers look higher. What you can see in terms of the trajectory here is something we hadn't realised until we did the case conceptualisation and really started going into the detail here. And that's a relationship that shows risk accumulating over the life cycle. So remember I said for the families who were extremely with the extreme involvement, that they had an average of 7 children in the family. It takes time to have 7 kids. Even though we see births closely spaced together, much more closely spaced together in our child protection involved families and in the broader population, 7 kids takes time. And So the story of reporting, number of reports to child protection, is also a story of the accumulation of family risk and need over time. And as these risks and needs accumulate, and as a system, if we are not able to effectively disrupt this cycle and to support those families in the healing, then we see more and more children being born in to the families, and it becomes harder and harder to support those families to change the more children you've also got involved, and where each of those children is presenting with multiple and complex needs. And you'll see there that actually only 9% of the sample had an average of one child. There'd only been an average of one significant partnering, and only 3 unique reports to child protection. And really, when we think about the interventions that we've got out there for families, most of them are designed for the lower end, the bottom end of this trajectory. So for the first 5 years and then that middle childhood. And most of the interventions, when you look at the evaluations, they're often effective for children where children are under 5, or they're effective for children who are under 12. But once we get into that adolescent group, which is really quite a significant proportion of our sample, 34% of the sample had an eldest child in later or early adolescence, then we have far fewer effective interventions to choose from. And the complexity for that family is so great that we're starting to get into problems that are becoming really resistant to change. Now, I want you to turn your minds now to voluntary family support services. As I said before, this is kind of one of the primary things that we're referring families to from child protection. And this is one of the primary things that I've in the past said we need more of. We need more voluntary family support services, and that's how we're going to disrupt, we're going to address demand on child protection, how we're going to stop all of this noise of reporting. Family support services are a really vital part of our service system, but practitioners in these services and the families are really doing it tough. If you think about the service model, we have a monodisciplinary model, so a single practitioner, typically social work qualified. Their role is to undertake assessment, they do case management, some counselling, parenting skills development. This is kind of the common suite of interventions. There might be some brokerage funds, and really critically, they rely on referral, and that's a core element of the family support service model, is this reliance on referral for supporting the family around mental health concerns and drug and alcohol misuse, relying on referral for housing supports, and for practitioners in these services who are relying on referral out for some of the kind of primary underlying causes of the problems within the family, they have no control over wait lists for services, over the sequencing of interventions. If we're thinking about this as a family problem, then you would really want to go through a process of stabilisation in terms of violence, the mental illness, substance misuse. You would want to support parents in terms of their healing before you were to intervene to support healing around for children in relation to their trauma symptomatology. Every effective intervention for children's trauma says, don't do this unless a child's in a safe and stable environment. So sequencing actually really matters. We wouldn't want to go launch straight into parenting skills development if the family still is homeless and doesn't have a house. So sequencing really matters in terms of thinking about how best to support families with multiple and complex needs, and thinking about the individuals involved in that family, each with their own set of needs. and our practitioners don't have any control over that with the model that we've given them. So where did we land in terms of rethinking our assumptions? I don't know if you heard all that, but that was my stomach rumbling. Must be lunchtime. I hope you all got a sandwich. So in terms of child protection systems assumptions, what we concluded is that reporters are actually reliably identifying families with the most complex needs. You know, we spend an enormous amount of effort and time screening out child protection concerns, working out within child protection what not to do, you know, where we don't have to intervene as a statutory agency. Families with multiple and complex needs are the largest population known to child protection. Now, for a long time, we've been talking about families with multiple and complex needs being a critical cohort. I just had not realised the extent of it. You know, we saw only about 10% of families who didn't fall into that category. There's insufficient services that are designed around the needs of families with multiple and complex needs from a family systems perspective, thinking about the needs of both parents and the children. There is such a dearth out there of capacity in terms of trauma counselling for kids that even when we're working effectively in order to keep kids safe from re-victimisation of further abuse and neglect, when practitioners have that win, which is amazing, then because we don't have that capacity in the service system for trauma counselling for kids, we're still not actually disrupting that trajectory. Similarly, if we remove children from families, we are still not disrupting this trajectory because we're not supporting kids to effectively heal. We're seeing child protection screening, it's contributing to rather than preventing growth in demand for child protection system, because it's a triage system, and it's a triage system that actually doesn't get to the end of the line. If you don't get to the end of the line in a triage system, you know, about 70% of cases in South Australia at the time we undertook this research that were screened into child protection actually didn't get an investigation. They were screened in, they were supposed to get an investigation, and the child protection system just couldn't get to them due to demand. If you're not getting to the end of your list, of your triage list, then triage is going to miss those windows for intervention, because we're going to see families drift through systems known by everybody, all of the agencies around them, but we're really not proactively intervening at the optimal times to support them in change. And the growth in demand is exponential. We all know about transmission now with COVID. It's a similar analogy for child protection. We are seeing exponential growth in need based on the number of children that we're failing in families, and with an average of 7 kids in families who are extremely involved, an average of 4 kids who are referred to child protection in families involved are referred to child protection. That's a really high rate of transmission, and over short generational cycles because of that early parenting. So what do we need to do differently? Well, we urgently need to change our systems and services to better respond to families with multiple and complex needs. And to be child and family centred, we need to design around the characteristics of those families. We need to provide support and development to practitioners who are responding to this complexity. My hat goes off to those frontline practitioners who are in the audience today. One size does not fit all, and we need to focus our systems design and services responses on priority cohorts who are driving current and intergenerational demand. Within the ACCP, we're taking a Centre for Disease Control approach to the epidemic of unmet need. So we are doing the work around the epidemiology and optimal intervention points. We're looking at, is our investment aligned in terms of what the evidence says is effective? Are there gaps for particular priority cohorts, like the gap I highlighted for effective, there's just not enough effective trauma treatment available for kids. We're looking at how we select and adapt effective interventions to the Australian context, and where there are gaps in that evidence, and we still have a lot of gaps in the practice evidence for this field. The science of child protection is still in its infancy, really. We started in the 1960s. We're looking at co-design and development and trial and evaluation of new interventions, and supporting scale up through supporting organisational change and workforce development. Some of the priority cohorts that we're focusing on in terms of trying to reduce current demands is that reactive severe violence perpetrated by mostly men with trauma-related childhood brain injuries. And we're really interested in the work of Tony Butler and Peter Schofield and the reinvest model, which combines pharmacotherapy with psychological intervention for violence perpetrators. We're very interested in the results of that RCT that's going on. The pilot was phenomenal in terms of the results on violence reduction, and interested in whether you could pair that with interventions for the family. Tertiary therapeutic and statutory intervention for large families with extreme child protection involvement, that 20+ reports, including children aged over 10 years. We actually don't have any globally effective interventions that are designed for the presentation we saw in that cohort. Similarly, the tertiary therapeutic and statutory intervention for the young families with multiple and complex needs. We would, again, this is where right now, these are the families who are out there being seen in family support services. We're interested in whether we can start rethinking some of the design of those services. Some of the things I'm interested in is whether you can potentially bring some of those specialist services like AOD, mental health, into the program, so you've got a multidisciplinary team who with the specialist skills to respond to those tertiary presentations. And Aboriginal and Torres Strait Islander children and their families across all cohorts. In terms of intergenerational prevention, and this is really different to what I would have said before doing this research about what I thought were key kind of priorities for prevention, but these are my prevention priorities now. It's that therapeutic treatment for the children under 10 with trauma histories to prevent those problems becoming entrenched and escalating during adolescence. We're undertaking quite a large scale of work in Western Australia, where we're actually trying to support the existing service system existing practitioners to build their capacity to provide therapeutic responses to trauma. When we did some survey of practitioners' needs, they said, look, we understand how to identify trauma, we know about how to talk about it, but the therapeutic techniques, we're not as confident in. So that's an area that we're working on as a statewide development in WA. It's a priority to be looking at therapeutic interventions for adolescents at risk, including early parenting prevention. If we can help those adolescents to heal, if we can delay pregnancy until they're 25, we could see a huge reduction in the number of families who fall into that extreme involvement category. It was those parents under 20 that are our biggest demand drivers. Similarly, seeing that intervention for first-time parents with trauma histories and multiple and complex needs. Again, Aboriginal and Torres Strait Islander children and their families were a priority across all of these, within all of these cohorts. I guess what I wanted to do was close with a call out, really. I think this is we have a collective challenge to reimagine how we provide services to families with multiple and complex needs. And I wanted to share with you an example of one of the ways that we've tried to think about how to redesign things within existing funding envelopes. It's not for families with multiple and complex needs, but funding is so often the challenge for us in reform and service redesign. One of the things that we were able to do in WA, where we had an ineffective response to children who were coming for a forensic interview following a disclosure primarily of child sexual abuse, was to be able to, we saw a non-government organisation with Western Australian Police really take the leadership. We were able to take an existing child abuse squad from the police. The non-government organisation provided a child advocate, and through the Medicare system, we were able to beef up the funding to the team of psychologists. Child Protection put an intake worker in, and the Princess Margaret Hospital attached a forensic paediatrician to it. So within the existing service envelope and organisations that were already responding to these families, we put them in one building, and we got them to think about how to work at an individual level as a multidisciplinary team. We saw that families getting a much more holistic response. Practitioners were actually had greater sense of morale and productivity within that team. So I put it out there as, I guess, just a way that we might be able to think differently about how we can reorganise ourselves to respond better to families with multiple and complex needs. A lot of the data in this presentation, it sits heavily when you think about the extent of the problem and the amount of demand. I think that, you know, for me, it needs to sit heavily. I wouldn't be paying attention to the data if it didn't, and remembering that every single one of those numbers is a child and a child's life. But it's not just about, you know, sitting with that awful feeling. To me, there's hope as well. There's an urgent need to respond, but, you know, we're an innovative, creative service sector, and I think that working together, we can start working off the right assumptions and start really solving the problem of child abuse and neglect. Thank you.
Well, Leah, that was fantastic. We've still got 300 people online and loads of questions. So I might just try and pick some out. Lots of comments. So lots of comments relating to the sort of multidisciplinary team approach. You talked about the levers. Actually, family support services don't have all the levers. Lots of comments about the role of kinship carers, so family support. But there is a question here about wondering what you think the role is of also addressing the other developmental needs early on. I think your comments about there not being trauma services for children is so on the money. I mean, there's very few services for children generally, so it sort of makes me feel like I'm not going mad advocating for that, because you've confirmed that. But given, I'm just going back to the question because it's jumping around, sorry. So given the high rates of developmental need and the subsequent impact upon education and life trajectory, do you see the main interventions being about addressing trauma or some of the other practical needs that children have?
Oh, I think it's both.
Yeah.
Absolutely. And we need to continue to do what we're doing well. You know, this is not about taking anything away from families. We absolutely need to respond to the developmental needs of children and adolescents. We need to provide that support to families, to just be families. Parenting payments for single parents are not enough. Poverty is still an issue. But in terms of some of the priorities in thinking about how to reduce demand on child protection, I would see really the overlying writing themes being about better responses to complex trauma across the lifespan, effective treatment there, and responding to the problem of domestic and family violence.
Yeah, absolutely, Leah. This is a great comment from Lynette Boy. And the way we support our families remains focused on coordinating them, linking them to services, adding additional demands in their already complex lives. Instead, we should stay close and build their capacity together. We need to change our practice, reform our practice to be of use to families. Does that resonate for you? Because we do just send people off to services, and often those services are not there.
Absolutely. And that example I gave about where we kind of were reimagining how we responded to kids who needed a forensic interview, one of the assumptions there we made was that we needed to move the service to be out where the family was and put all the services together into one child and family friendly building and make it easier, because things are hard enough. When we start to reform systems by adding a service coordinator or a referral network, then our service system is probably not designed around children and families at the centre.
Yeah. I'd like to ask a question about our First Nations people. This is from from Kathleen. Thanks for your presentation. Really interesting information, not surprising, but provides clarity. I mean, actually, clarity is so important in this area. The question is how you imagine engaging with our First Nations people around this. We know that they are overrepresented in these issues, and her belief is that we need to be strongly led by their community to address these issues. And here in Victoria, we've got some really fantastic work going on, but there is a huge amount of work to yet do.
I totally agree, Kathleen. Self-determination is one of the major principles that we adhere to within the Australian Centre for Child Protection. For some of the work that we're currently doing around co-design, if I can kind of give an example there, we were given a grant to look at designing, working on what's the most effective therapeutic responses to complex trauma, where the evidence base is much thinner. Now, when we worked out that there was no international model that we could just select and adapt, and we really needed to take a kind of a components or a common elements approach to that design, we started to think, well, why would we design for non-Aboriginal children first and then adapt for Aboriginal children? So we went to the community, Aboriginal community in WA, and said, would you like us to flip it? Start with Aboriginal kids. So that's what we're doing. We've flipped it to start with Aboriginal children. But along with that decision meant that we needed to really give away that decision making. So there's now an Aboriginal chief investigator for that grant. There's an Aboriginal cultural oversight group who have the authority. I can't, as the system we've set up is that I can't override them. We can provide evidence to inform, but to do it properly, we had to genuinely, we have to give away power to an authority.
Absolutely, Leah. I might end on this because I think you did say to this in your closing remarks. And there is some sentiment in this in the questions, and I'm sure you've seen them, about how sad this is. But you also talk. I feel like you. I feel hopeful because in fact we have to. But like, what would your comments be? I mean, I'd have to say that here in Victoria, I know I've got a few of my colleagues on the line here. We're doing a piece of work on the future of the child protection system here in Victoria. I know that you've been interviewed for that. But my colleague here, Trish Rex, said, I hope that we're not talking about this in 10 years. So do I. So I might ask you to make some closing comments, because these are big questions, but we all know they're fixable. They are, if we put our minds to it and we get all levels of government to engage on this.
I found when we first saw this data, I have to say I was very heavy-hearted. It's depressing. It really is. And when we're all in this sector for in the best interest of children, then it's devastating. And I felt personally accountable for all the times that I had given advice based on the wrong assumptions. But for me, there's massive hope in this as well, because really for the last 10 years, we've been reforming our systems based on the wrong assumptions. It's not that we've created something new. We're just taken off the blinkers. And to me, I'm really hopeful because this gives us the chance to solve the right problem and actually give our kids the greatest chance for a positive future, and to make it better for their parents and for the practitioners out there in the front line. So I'm really hopeful that we can solve the right problem now.
Me too, Leah. And I think that you know, we do need to we do need to sort of honour the research that you've done and now take that forward. I'm pretty excited because I can feel I'm just going to take some of this and in our advocacy use it. I just want to thank you so much for being with us today and for privileging us with your research and the information that you've gathered, and to be so honest with what the research is telling us. We do have a whole lot of questions and comments that we haven't really been able to get through. I know Leah's really busy and she will help us as she can to try and answer those in due course. So don't panic too much. I want to thank you, Leah. It's been fantastic and insightful. Confirm some things that we knew in a way that we didn't have the evidence to support what we instinctively knew, but it gives us some new assumptions to go forward on that has some concrete research behind it. So thank you so much. Let's give Leah a bit of a virtual clap for those that are still on the Zoom meeting today. And I know many of you are hopping off now, going back to your sort of your regular meetings. So thank you so much for being with us.